Morning, everyone. I am Dr. Vikram Khanna, and I am going to speak on the biology of bone distraction. Distraction osteogenesis is the mechanical induction of bone tissue produced after slow separation of the two bony segments. It is that inherent capacity of the bone tissue to regenerate and remodel according to the mechanical and the tension forces. It was first described by Ilizarov and later perfected by Ilizarov. Principles of distraction. For good distraction osteogenesis to occur, the osteotomy has to be low energy so as to protect and preserve the soft tissue and the periosteum. It needs to be fixed stably. Both the fragments have to be fixed stably so that the regenerate quality is good. Uh, After the osteotomy, a proper latency period should be there, depending on the amount of damage and the age of the patient and the location in the bone, and good appropriate distraction rate should be used. Now, this is the law of tension stress, which basically governs or actually explains how the Ilizarov technique works. It is the gradual traction of the certain living tissue creates stresses which can stimulate and maintain regeneration and active growth of that tissue. Now, for the growth to happen, there are three components which should be there. One is progenitor or stem cells. Then there are growth factors which activate those stem cells or the progenitor cells. And a 3D scaffold has to be there on which those stem cells grow. Now, coming to the biology of bone distraction, these are the topics on which I'll be talking on. So coming to the frame application, can either be done by the circular or the Ilizarov fixator or the unilateral fixator. So the ideal lengthening apparatus should avoid torsion or shear, allow cyclical micromotion, weight bearing should be there, it can be there, and it should allow modification. It should be very modular. So in both the categories, in Ilizarov also we get quite good modularity. And now with LRS, multiple clamps are there. And with the alpha fixator also, we are able to get good modularity in the fixator. Advantages of the circular frame fixation. It controls the axial alignment. Simultaneously, we can correct the deformities also in the bone. Differential lengthening can be done, and it can be spanned across the joints. Just like if there is a very small fragment which is there, distal fragment in the distal femur or distal tibia, so we can span it across the knee joint or the ankle joint respectively. So osteotomy or corticotomy, separation or the fracture of the two fragments either from the metaphysis or the diaphyseal region. Then there are three types, osteotomy, corticotomy, or osteoclasis. Mainly the healing occurs from the periosteal blood supply. However, Ilizarov was of the concept, was of the thought process that the intramedullary blood supply also plays a part, but it's not been proven yet. So the corticotomy term was termed by Ilizarov. It basically is the low energy cutting of the cortical bone and trying to preserve the periosteal and the endosteal circulation. Now, there are types of corticotomy according to the direction. It's transverse, oblique, spiral, or step cut. According to the exposure, it may be percutaneous, minimally invasive, open. The device which is used, it may be a power saw which is used, or an osteotomy or a jiggery saw. Now, according to the direction, what is the advantages of a transverse osteotomy is that it is technically easy to perform and it is easier to visualize. Whereas with a spiral or an oblique osteotomy, we get a good bone surface, so there is good healing, good regenerate formation, and it is inherently stable. Now coming to the classical corticotomy, it was initially described as a percutaneous, subperiosteal, metaphyseal, and done with an osteotome. But in obviously, like for the bones, the surface, like for the tibia, the description was that the anterior, medial, and the lateral cortex was broken, but the posterior cortex, it was little, since the soft tissue coverage is posteriorly mainly, so we have to be extra careful while doing that. We have to make sure that the periosteum doesn't get damaged all across. Then the corticotomy then the healing and regenerate is affected. Now coming to the modifications, uh, we can either use two small incision and make a subperiosteal osteotomy, or we can drill the cortex with holes and then do a subperiosteal osteotomy under vision. Main thing is the word subperiosteal. So if the osteotomy is subperiosteal, we get a good regenerate because the healing is much better. Now, the site of corticotomy, it can be done in the metaphysis or the diaphyseal region. The metaphysis is obviously is a good, better area for the osteotomy, as it has a massive trabecular area with rich vascular, rich collateral vascularization and good fracture recovery rate. Coming to the latency period, that's the rest after the osteotomy. It gives a chance for the organization of the hematoma and the periosteal revascularization. Also, fibrous tissue matrix is formed on which the osteoblasts will proliferate later on. At a range of 4 to 7 days, we can go up till 14 days. But all that depends on the age of the patient, the area of the osteotomy, then the amount of damage caused during the osteotomy, and if there is some primary pathology which is going on. So the rate of distraction, there were multiple studies in which first study was when the entire gap was distracted in one go. It showed non-union in all cases. Then sporadic distraction 1 to 1.5 mm was non-union in all cases. Auto distraction, that is around 60 times a day, in that the fibrous interzone is rarely seen and it generally leads to premature consolidation. So if we say that the rate per se, 0.5 mm per day will lead us to premature consolidation. 1 mm per day gives the best regenerate, and 2 mm per day gives a poor quality regenerate. Obviously, once the distraction starts, then we can always judge what is a good rate for the patient and that area, because the thickness of the regenerate can guide us. If the regenerate is coming out to be very thick, then we may accelerate the rate of distraction. Whereas if the regenerate is coming out to be thin, then we need to go slower, because if there is thick regenerate and if we continue going slow, then that might lead to a premature consolidation. That is again that again varies from patient to patient. So we have to be very careful when we see the post-op X-rays and the X-rays which are showing distraction, so that we come to know. These are the X-rays which show poor quality regenerate, and on the lateral view, we can see that regenerate cyst is near about forming. This will eventually go for a bone grafting, curettage and bone grafting. So the rhythm is 0.25 mm 4 times a day. And again, we have already discussed the faster and slower rates. That depends on the basically amount of the regenerate thickness which is being formed. And limiting factors are the fibrous interzone is more than 1/3 to 1.5 of that regenerate, neurovascular compromise, and joint contractures. That is one thing which we have to take care. We have to be very thorough in our clinical examination in the distraction phase. Alignment is of utmost importance because once the lengthening is complete and the patient has to walk, if the alignment is not right, then the regenerate, the mineralization of the bone, the mineralization of the regenerate, that will not happen adequately. Coming to the distraction week 1, we see the fibrous interzone present. This is basically hypovascular fibrous tissues, which consists of parallel collagens along the direction of the distraction, and they are interspersed with fibroblasts, and there are no osteoblasts which are present. In the week 2 subsequent, the distraction continues. The fibrous interzone is there, and it is there like around in the middle 4 around approximately it is there. The collagen again gets more organized. There are conical microcolumn formations which are there, but they are very faint. Fibroblasts then are converted to osteoblasts. Mineralization starts. That is like the microcolumns are indication that the mineralization is starting. Then there is a primary mineralization front, which is there next to the fibrous interzone, and vascular channels now extend up to the fibrous interzones. In the distraction week 3, the fibrous interzone remains as such. We can see a radiolucent area in between the regenerate. There is nothing to worry about. Elongation of the microcolumns is there, and vascular sinuses are present along the primary mineralization front. And in this image, it is very well depicted what I'm saying. The fibrous interzone in the center, next to it is the primary mineralization front. Next to it is the microcolumn formation with the vascular sinuses in between. And there we see the histological pictures as well. Now, once the distraction is complete, the fibrous interzone disappears. The microcolumn bridge the entire gap. Vascular channels start crossing over to the other side because the fibrous interzone has disappeared. So, the vascular channels now bridge the entire gap. There is a single sheet of bone throughout the regenerate, and if the regenerate has, if the fixation is not stable, it is or the distraction rate is fast, then maybe it may lead to cartilage formation, which may show radiolucent areas, like we've seen in this very well. So coming back to remodeling, in this stage, the corticomedullary differentiation occurs, and the bone attains the normal vasculature with a good marrow formation. The blood vessels, when stretched, initially when they stretch, then there is temporary degeneration, but with the help of the angiogenic growth factors, the regeneration occurs, and in fact, better blood supply is there around 8 to 9 times at the time of regeneration. So the muscles, there is stretching of the muscles, and later there is neohistogenesis of the in the muscles. That is the bone, the muscle growth, muscle lengthening is there. But if you stretch it beyond a particular point, then they might lead to damage. So the damage is clinically present as contractures, and we have to be after the initial stretching. It is very essential to focus on the physiotherapy, otherwise the neohistogenesis does not occur. After the regeneration is over, we go for the holding period, that is 1 month for every centimeter. However, it is not the per se law types. We can go for a longer period depending on the amount of the age, the location where the osteotomy has been done. So the holding period will be at least till three cortices are seen united on two orthogonal X-rays. Oblique views may help in determining whether the bone has united or not. And for removal, I would say that it is better to first give that regenerate a little bit stress by reducing the distraction, pulling it back a couple of millimeters, and making the patient walk to see if there is any pain or any changes in the regeneration, or we can also confirm it with X-rays. So all these things, before we take out the entire fixator, we need to be absolutely sure, because a month extra of the fixator is far better than a day earlier in removal. These are the local and systemic response triggered by the distraction histogenesis. I'll not go into the details because it's basically not the most significantly we can see that in the initial stages, when the latency and the active distraction, the inflammatory markers and the angiogenic markers are higher, and as soon as we go to the consolidation phase, the osteogenic factors take over. So we can maybe use these biological factors as a biological interventions and biological factors to improve our regenerate quality and faster recovery. They include weight-bearing accordion, electromagnetic, hyperbaric oxygen, lithium, magnesium, then platelet-rich plasma, levodopa, parathyroid, so on and so forth. So maybe these can be used, but nothing replaces a good stable fixation, good alignment, and proper osteotomy, low energy osteotomy, and preservation of the soft tissue and the periosteum. Coming to the summary, distraction osteogenesis depends on the stability of the apparatus, soft tissue preservation, rate and rhythm, latency period, level of osteotomy, and physiological loading. Under ideal conditions, low energy osteotomy, preserving blood flow to each opposed surface, distracted at a regular increment rate of 1 mm per day by a stable external fixator system, will reliably regenerate a new bone segment of similar macro and microstructure. Thank you.